How do I do that? Here? Okay. So I wanted to get started on time. As you can imagine, this is a huge topic. In fact, I combined several, like 3 of the BCOP topics. So I'd like to point out that this is not an exhaustive review of supportive care, but I thought it would at least get you started studying and maybe be a good review for the rest of us that aren't taking the exam. So some of the guidelines I think everyone should be aware of, whether or not you're taking the BCOP, are the ASCO guidelines. So I put actually a link within the slides. It's a little bit hard to see on this one, but we'll send the slides out a little bit later. The MASC guidelines, the Multinational Association of Supportive Care in Cancer, and these are actually international guidelines, but some of our guidelines that we're going to talk about this morning come from there, as well as the NCCN guidelines, and you can just sign up for a free account and they send you tons of emails about updates to guidelines, and they allow free access to their guidelines, which a lot of the insurance companies now are using to approve different regimens for patients. So the first thing we're going to talk about this morning is anemia and the use of erythropoietic stimulating agents. And in this one, the most recent guidelines available are the ASCO guidelines from 2010, as well as the NCCN guidelines that were just updated in February of 2015. So here's our first case. So AC is a 69-year-old male receiving his 3rd cycle of cisplatin etoposide for extensive stage small cell lung cancer today. At diagnosis, his hemoglobin was 13, so in the normal range. Today, his hemoglobin is 9. So he has a history of COPD and complains of significant fatigue, which interferes with daily activities. So he's symptomatic. His weight today is 75 kilograms. So which of the following is most appropriate according to the guidelines? And we'll talk about this later, but just to test your incoming knowledge, is it, I'll let you read them. And? Anybody?
Dave, can't you start it? You can start it now.
What?
Couldn't you start it now?
Mm-hmm.
Hemoglobin's under 10.
Yeah. According to the guidelines. So actually the answer is A. So it's epoetin alpha, 40,000 units weekly starting this cycle. So basically the ASCO guidelines talk about the FDA label, right? It limits the indication for use of these agents to patients that are receiving chemotherapy for palliative intent. So our patient on the past slide does, it does apply for him because he is small cell lung cancer, extensive stage, so we're not going to cure him. So you have to weigh the harms versus the benefits, and no study has really evaluated the outcomes of ESA therapy by subgroups defined by chemotherapy intent. The ASCO guidelines consider EPO and DARBI equivalent in both safety and efficacy. And there is a threshold for initiating therapy from the ASCO guidelines, so it's an option if anemia is A, both chemotherapy associated, and B, the hemoglobin is less than 10, with the intent to decrease the need for transfusions. So there is this gray area, so initiating therapy when the hemoglobin is less than or equal to 10, but less than 12, the decision should be based on clinical judgment weighing risks and benefits. And then the initial doses is either 150 units of epoetin 3 times per kilogram 3 times a week, or 40,000 units weekly, which is the one we chose on the previous slide, and the DARBI doses seen here also. So what are the risks of ESAs in cancer patients? Why do we worry about it? So there is, of course, the increased risk of thromboembolism, and this has been well established in cancer patients, as well as we need to recognize the risk factors in your patient. So chemotherapy, obviously, patients that are on BEV or cisplatin-based have higher risks of thromboembolism as well as certain tumor types. We know that pancreatic cancer patients, primary CNS patients, have higher risks of thromboembolism just at baseline. And of course, the other one would be immobility, which as in all patients. There are risks of hypertension, so watch it if your patient is receiving therapy associated with hypertension and occasionally seizures. So what about treating anemia in patients not receiving concurrent chemotherapy? So the cause of anemia is often multifactorial. It can be the cancer itself. It can be bleeds, if they're bleeding into the GI tract. So ESAs are generally not recommended for these patients. It's an unfavorable risk to benefit ratio for use. Exception would be the use of ESA in myelodysplastic syndrome. So if you see myelodysplastic syndrome on the test, that's a different topic. So anemia in patients with non-myeloid hematologic malignancies that are receiving concurrent anti-cancer therapy, basically you want to treat the malignancy and follow the relevant labs before using ESA therapy. Anemia may certainly be from malignancy-related factors that are improved with anti-cancer treatment. So, for example, anything that would involve the bone marrow, like myeloma and leukemias, you'd certainly want to treat the cancer first. You can consider ESA if you're not treating for cure, if the hemoglobin doesn't increase as the malignancy is hopefully under more control. So anemia in patients not receiving concurrent chemotherapy, duplicate slide. So moving on quickly, I guess, to the use of white blood cell colony stimulating factors. The ASCO guidelines are from 2006. They haven't been updated in a long time. There really hasn't been much change. The IDSA guidelines were updated in 2011, and the NCCN guidelines haven't been updated since February of 2014. But all of these organizations do have guidelines for this that you can look at. So here's our second patient case. So AP is a 61-year-old female, status post cycle 2 of cisplatin etoposide for limited stage small cell lung cancer. It was given 10 days ago. The labs today, the white blood cells, you can see there. The vitals, she comes in with a fever of 102. Blood pressure appears to be a bit low. All of these are like hints. Complaint of cough with pleuritic chest pain. And she's admitted to the hospital and started on meropenem against Dr. Fox's wishes. So which of the following should be added to her antibacterial regimen? You on the phone can join in too. I see C, and that is true. C would be the correct answer. So pegfilgrastim, right? Probably not a good idea at this point. Sargramostim, the 5 mics per kilogram, is not the right dose. So sargramostim, the dose is 250 per meter squared. You probably want to add Vanco to this patient, at least for a couple of days, and so that's why C is the right answer. So I've added this slide kind of as a summary of the different guidelines and what they say about the use of colony stimulating factors. And a lot of them line up. So we should always use colony stimulating factors for primary prophylaxis. So what's primary prophylaxis? Kate?
To prevent the white blood cell count from them becoming neutropenic so that they can continue chemotherapy and not have delays.
Right, so giving it up front with chemotherapy, that's right. So all 3 guidelines recommend that. So when the risk of febrile neutropenia is greater than or equal to 20%, that's a lot of patients being admitted or treated for febrile neutropenia. That's kind of a controversial topic. The primary prophylaxis, when between 10 and 20%, the other IDSA and ASCO do not recommend it, but NCCN does when it's done for curative intent. There's also certain subtypes of patients that they recommend it for, so more elderly patients, might get this when it's 10 to 20%. And that's the primary prophylaxis for high-risk patients, and those, all of them are yes. So anything that would put a patient in a high-risk category. So, like, one of the things that ASCO or some of the other accrediting agencies for cancer look at is when we give CHOP, are we using primary prophylaxis for the right subtype of patient? So that would be anyone over the age of 60 and that type of thing. So secondary prophylaxis, and what is secondary prophylaxis?
So maybe if they've become neutropenic after a cycle of chemotherapy, you might add it back in so you don't delay
Right.
again and have to dose reduce.
Right. So if they get febrile neutropenia and then during a previous cycle, then should you do it? And as you can see, that's pretty non-controversial also. So if you get febrile neutropenia, you've kind of bought yourself GCSF for the rest of that chemotherapy. Chemoradiotherapy, it's not even addressed in IDSA because they're just looking really more at febrile neutropenia and prevention of that. ASCO said yes. I think it really depends on, what type and where you're irradiating. Have you guys ever seen it used with chemoradiotherapy? It'd be pretty hard, I think. So not used very often. But the adjunct treatment of febrile neutropenia, so when do we use it in febrile neutropenia? When is it really recommended for use? IDSA says no, but they kind of say yes in very few circumstances. Do you know when we do use it for the treatment of febrile neutropenia?
Like high-risk factors.
High-risk factors, like what?
So like the patient case that you
Like elderly,
they look
unstable.
Yeah, basically an unstable patient. So they come in with like low blood pressure. They end up kind of like an ICU type patient usually, or IMC, intermediate care. It wouldn't be someone that just has a fever. Or, once you give them a bolus of fluid, their blood pressure is fine, But it would be for patients that have other kind of factors. So that patient that we had does qualify for it because her blood pressure was like 60 over 40.
So on the BCOP, if they have questions on this,
Mm-hmm.
do they relate to a guideline, or you just, since some of them vary in the recommendations?
So they don't ask controversial questions. I went to a question writing workshop this year where I wrote questions for the BCOP. So I kind of learned a lot about what they do. So anything that's controversial, so like this primary prophylaxis for 10 to 20% wouldn't be on the test because it's hard to distinguish and to have everyone know the different categories. Would you say that's true, Jason? Jason just took the exam.
And they're not going to say like per ASCO.
No.
Okay.
Well,
it wasn't controversial. They would say like per NCCN.
Yeah.
They wouldn't ask controversial questions.
Yeah.
Okay.
They
Yeah.
wouldn't ask you to tease between guidelines.
Yes, I think knowing kind of the more general stuff is the way to go for BCOP. So cardiovascular toxicity, really the only guideline for this is in the ASCO in 2009. Again, hasn't been updated in a long time. So here's another patient case. And these all actually come from BCOP, so to give them credit. But TC is a 46-year-old male with stage 3 colorectal cancer receiving cycle 1 of Folfox. You don't have to worry about the Folfox 6. They're all pretty similar. On day 2, he presents to the ED with crushing substernal chest pain. Basically, his troponins elevated, his electrolytes are within normal limits, he has ST elevation and bundle branch block, and within 36 hours in the cardiac care unit, his symptoms abate. So which of the following is the most likely cause of TC symptoms? B is correct. I like C, but probably not the right answer. That would probably be me. But yeah, so 5-FU is well known for causing these coronary vasospasms, especially the higher doses of it that you see in like Folfox, right? So you give a pretty high dose over 46 hours. That's when you see the coronary events with 5-FU. So we all know that a multitude of anti-cancer agents are associated with cardiovascular toxicity, lots of different clinical presentations. Most commonly encountered include the 5-FU and, of course, capecitabine, right, because capecitabine basically is 5-FU. TKIs that affect the VEGF pathway, they cause hypertension, heart failure, and or thromboembolism. And then TKIs that affect the VEGF, BCR-ABL or HER2 may cause QT prolongation. So a lot of the drugs that we use in general cause QT prolongation and can cause problems. I did put some references there too in case you want to look up some of these things. So other important cardiotoxicities, we talked about the coronary vasospasms that was correctly identified in our patient case with 5-FU. Arsenic trioxide causes arrhythmias, so we're always really careful with that one to watch electrolyte, magnesium and potassium, make sure they're within the high normal limits. Hormone blockers can cause coronary heart disease, so the drugs that we use for prostate cancer and breast cancer. And paclitaxel and ixababolone, which I can never say, both cause bradycardia. Ian Robbins told me he would not give that drug to a dog. Okay. It was just a random conversation once. So dermatologic toxicity, Ian Robbins, for those of you that don't know, is our kind of CNS, and then he does some metastatic breast guru. So dermatologic toxicity, the MASS guidelines have a really good guideline on this from 2011. I would look it up and read it. It's, I think, very well done. So PM is a 75-year-old male with metastatic colorectal cancer, and he's scheduled to receive his first dose of panitumumab in clinic today. We're going to be using more panitumumab around here. So which of the following is most appropriate to manage the EGFR inhibitor-associated rash? B is correct.
Although they don't usually prophylax like the physicians or docs.
Yeah, I think we may need to start intervening on that and talk to the GI group again about using this. This is pretty well established. Have you seen?
They'll prescribe it and send it with them, and then just as soon as anything starts,
As soon as the rash starts. Yeah. They really, I mean, the guidelines all recommend using it prophylactically, and now that we're going to be using panitumumab where the rash is more of an issue, I think we may need to start pushing that a little bit more. Anyway, that's another project somewhere. So dermatologic toxicities, as we all know, have many different presentations. A lot of our different cancer drugs or chemotherapy drugs cause it. Refer to the handout for discussion of these toxicities. They actually do a very thorough job. And the most common toxicities to know as far as the tests go would be the Palmer-Plantar erythrodysesthesia. So that's in the colorectal cancer handout because you see it with what drug? A lot. Five FU and capecitabine, as well as regorafenib. And then EGFR1 inhibitor-associated rash is, of course, well known and well documented in the literature. So the EGFR inhibitor rash is so this receptor actually is expressed in the skin. So it makes sense that you're going to see a lot of skin kind of reactions with it. So it occurs in about 85% of patients. So that's a lot of patients, right? And it's often maculopapular and or acneiform. So it looks like acne, which is very odd on a 75-year-old man. And I think really distressing for patients. So symptoms peak in weeks 1 through 3 of the therapy. They usually diminish by week 5 to 6, despite therapy being continued. And there are changes in presentation over time. And this particular reference is a pretty good review of this, in case you wanted to read the primary literature with this. So all patients that receive EGFR1 inhibitors should receive prophylaxis with hydrocortisone 1% cream twice a day, sunscreen of SPF 15 or greater, and doxycycline 100 milligrams BID or minocycline 100 milligrams daily. Doxy is preferred for patients with renal impairment. Minocycline is less photosensitizing, so patients in the south where there's a lot more sun, a lot more of the year, minocycline may be a better choice for those patients. I think there's almost always a question on this on the BCOP exam. Jason does not recall. There were a lot of questions when I was reviewing questions. So this is the treatment of EGFR inhibitor or EGFR1 inhibitor rash, kind of in a table. I think it's easier to learn this stuff sometimes when it's organized this way. So I'm not going to read this. You all can read it, but it's done by grades. So what do you add when a patient's rash gets worse? And this, again, comes from that supportive care in cancer that I talked about earlier. So chemotherapy-induced nausea and vomiting, something that we all work with every day. And you can see the guidelines that address this on this slide. So here's our next patient case. So JS is a 40-year-old woman with extensive stage small cell lung cancer, starting cis etoposide cycle 1 today. So what does this tell us? Cisplatin is what, as far as the metagenicity? High. It's like what all the antiemetic agents are tested against. It's kind of the gold standard if you want to be nauseated. Past medical history is also important to note in these patients. Depression, she has social ethanol intake, and motion sickness. So which of the following is most appropriate regimen to prevent acute chemotherapy-induced nausea and vomiting? This is not, I purposefully did not make this the UW guidelines because in general, our guidelines are much more restrictive than the national guidelines are, and you need to know this for the BCOP. So what's the right answer? D is correct. So all of those you can kind of tell why they're not. The A, that you don't need 20 milligrams of dex. B and C, there's not enough on Dancitron. So just be aware that unlike UW, palonosetron is the preferred antiemetic, or the preferred in this class, in the NCCN and ASCO guidelines. So despite receiving the correct regimen outlined in the previous question, so she calls clinic triage 5 days later and complains of significant nausea and vomiting. So which of the following would be most appropriate to add to her antiemetic regimen at this point of those 4? If anyone says D, I'm going to be really upset with you. Actually, A, out of this choice. The doses are wrong on the B and C. So haloperidol, you'd have to use a larger dose than 0.25 milligram to get an anti-nausea effect, usually 1 to 4. Dermavenol, you need to dose more than once a day. So that would be why those are not correct. We don't use a lot of metoclopramide here. It is one of the recommended interventions for breakthrough nausea and vomiting. So I think being aware of that for the exam is good. You have to kind of forget the UW way of doing things and learn the national guidelines. And we should know that anyway as professionals.
Is there a reason that they don't use it much here?
Palonosetron?
No, the medical.
I think it's just kind of general, kind of historical more than anything. I think we should use more metoclopramide than we do. Jason, do you ever recommend it in clinic?
I was gonna say Gynac uses it a decent amount, so Medicaid
Yeah.
more than Gynac uses it more than
Yeah.
Does Gynac use it more than anybody? Yeah, it works pretty well. So studies really haven't shown superiority, right, of one agent to another for the treatment of breakthrough chemo-induced nausea and vomiting, or CINV. So, but do understand that restarting aprepitant in patients with breakthrough CINV has not been studied. It's very expensive. There's no evidence that it helps, and we shouldn't be using it. So all of those three drugs, as we talked about, could be used in this case, but the doses are incorrect. Uh-oh. So chemotherapy and metagenicity, see the handout that's posted online. I think most of us know about this. You should know, I see a lot of cisplatin on the BCOP exam when they're trying to test highly and metagenic, and maybe I rarely see them test moderate and minimal, but I guess knowing some of the more common ones, you don't have to know every drug in every class. But you also have to remember when talking about CINV that patient factors do play an important role. We all like, as pharmacists, to have very strict guidelines, but you really have to know the patient. So previous experience with CINV is important. Psychosocial aspects like depression, sleep deprivation if they're having trouble sleeping, those can all cause more nausea. Women have more nausea than men, which does not seem fair. Nevertheless, children have more nausea than adults, so that's why the guidelines for children are a little bit different. History of motion sickness or morning sickness causes you to have more. However, if you're abusing alcohol, it's a good thing in this one instance because it is protective against chemo-induced nausea and vomiting. The one time we can say alcohol abuse is helpful. So for highly and metagenic acute CINV, you want to use a serotonin antagonist plus Dex plus aprepitant or fosaprepitant. All serotonin antagonists are considered equivalent when used at equipotent dosing and irrespective of route of administration. So that's why we have chosen to use oral here versus IV, because there have been shown to be no differences. And dexamethasone dose is 12 milligrams when co-administered with aprepitant. So moderately emetogenic, ASCO says there's no data to support the use of fosaprepitant, but NCCN and MASC both say fosaprepitant can be used. I think for moderate, it's probably reasonable not to use it at first and then to add it on if patients have difficulties. And NCCN is the only guideline, which I think is interesting, that say aprepitant may be used with or without concurrent Dex. I know here we do occasionally if a patient doesn't tolerate Dex, but the evidence does show that it works about 20% better if given with Dex. So I'm not sure why NCCN said that. But both NCCN and MASC say palonosetron is the preferred serotonin antagonist now. And for moderately emetogenic for delayed CINV, both ASCO and MASC have single agent Dex as the preferred agent for prevention of delayed CINV, and I would know that for the test. So breakthrough CINV, all the metagenicity levels, and you can see here what the different guidelines add. So PEDS specifically, because PEDS is always different, right, Carrie? Carrie might have had to leave. So to prevent acute CINV with highly and moderately emetogenic regimens, use a serotonin antagonist plus DEX. There's no data to evaluate the prevention of delayed CINV in kids, and there's insufficient data to recommend aprepitant in pediatric patients right now. We do use aprepitant here, but just, I guess, note that the evidence really isn't out there yet to recommend general use. So the MASS guidelines from 2011 to prevent acute CINV with highly and moderately emetogenic regimens, you use a serotonin antagonist plus DEX. And I've already done that one. Sorry, I was putting these slides together pretty quickly yesterday. So pain management, the NCCN guidelines have really good guidelines for pain management in cancer patients. There's always questions on pain management on the test. So the first patient case, it's a 65-year-old male who presents to the clinic with increasing pain. So he's had intermittent pain since being diagnosed with stage 4 non-small cell lung cancer. The pain is now worse and is not being controlled by the acetaminophen that he was using on a regular basis. So which of the following statements would be true for him regarding his pain and pain management regimens? C. Pretty easy, right? So pain is one of the most feared consequences of cancer to both patients and families. And barriers to adequate pain control include provider, patient, and family, and system barriers. There's multiple risk factors for the undertreatment of pain. One thing that worries me right now is a lot of this talk about opioid abuse and all of the issues that have gone on with that. I'm afraid it's going to affect our cancer patients that really do need opioids. So some of the principles are to address and when possible treat the cause of pain. So if the cancer is causing the pain, sometimes just treating the cancer with chemotherapy will help with the pain. Maximize pain relief and minimize side effects. Be familiar with that WHO ladder. I think we all learned about it in pharmacy school. I think it was out there when I went to pharmacy school. It has not changed a lot. It's a long, long time ago. What's the WHO ladder? You guys all know, right? No?
I don't.
Is this like where you start?
Right. It's basically like a little staircase, right? So what's on the first step, do you think? Tylenol or ibuprofen, NSAID, something like that. And then like the second step would be like the mild opioids. So what? Tramadol, hydrocodone, they have on that step. A lot of the ones that are like combined, like they actually have like oxycodone and acetaminophen. And then the third step is the more potent opioids. Make sure you use oral agents whenever possible. And for the test, I would know some simple opioid conversions.
Yeah, there was a question on that. Didn't study that. I think I got it, but I don't know.
Yeah, I didn't expect it on my BCOP back, I don't know, it's been 10, 12. I'm on my second 7 years. It's probably 12 or 13 years ago now, but I still remember to this day, convert hydromorphone to morphine equivalent. So I think they keep it pretty basic, but I would know.
I would know the table.
I would know the table, yeah. Which one was on yours, Jason? Do you remember?
I think it was like a PCA conversion.
Oh, PCA conversion. So something that you would do on a routine basis. So adjuvant analgesics, I think I tried to organize it into a table that talked about the basic uses as an adjuvant analgesic for these different drug classes. So knowing that antidepressants, anticonvulsants, and antiarrhythmics are used for neuropathic pain, then when they say, what do you use, they talk about gabapentin with someone with neuropathic pain. That would be the answer for that. Bisphosphonates, we know, can treat bone pain, as well as some radiopharmaceuticals. Corticosteroids like Dex can be used for bone pain or nerve compression. And then these drugs improve sedation with opioids. So moving on to GI toxicities, except for CINV, which had its own category. So constipation. 45% of patients that are admitted to hospice have issues with constipation, causing symptoms. So it can cause pain, it can cause debility, nausea. Yeah, Kate's been doing a onc rotation, solid tumor rotation on the inpatient side. Most of the patients that are admitted to B66 have problems with constipation causing, or not most, but I'd say a good portion have problems with constipation that eventually cause an admission to the hospital. So this really is a big deal. We tend to think of it as very common, and it is, but it really needs to be addressed, especially opioid-induced constipation in our patients, as well as chemotherapy causes. So I've tried to organize the different causes of constipation into 5 different categories. Everyone can read these for themselves, but I think as we try to think through how to treat a patient and how to help them, trying to figure out what's causing the constipation is useful. So management of constipation, I've listed different medications on the left as well as on the right, what their use would be. These are classes of medications that we use to treat constipation. So prokinetic agents like metoclopramide sometimes can be used when the constipation is due to enteral feeding, or it helps with mild to moderate nausea and vomiting constipation by moving that along. So here we go. JB is a 64-year-old male, recently started on OxyContin, and he presents at clinic about 2 weeks later with complaints of abdominal bloating and fullness, and upon talking to him, you determined that he was not taking anything to prevent opioid-induced constipation. And what would you recommend and why? This one actually is not a multiple choice. So what would you recommend for an opioid-induced constipation? How many times do we see patients come back after being started on an opioid that are not on a proper bowel regimen? Often. And basically, if they're started on an opioid on a regular basis, they should be started on a bowel regimen. And I think that we need to figure out a system to make sure that that happens in clinic. It's another good project. Thinking of lots of projects. So what do you think? What should he be on? Senadocusate or Miralax? Yeah, it doesn't really say that, but you kind of want to know what his diagnosis is. That's a good point, Ethan. Because you don't want to, if it's a blockage of some sort from the tumor, you'd want to be thinking of that too. But this one isn't. So you want to make sure that they're on a stimulant laxative. Stool softeners are not adequate for opioid-induced constipation. They need to be on a laxative. So, or on a stimulant laxative. So the Sena with Docusate is kind of the gold standard, I guess. But Miralax also might work. So moving on to diarrhea, there's different types of diarrhea, secretory, osmotic, hypermodal, and exudative. All of these can be seen in our cancer patients, and I think understanding and being able to delineate the different types of diarrhea is important. It's seen with many chemotherapy medications. In general, continuous infusions have caused more diarrhea than short infusions. 50 to 80% of patients that receive 5-FU, irinotecan, or combinations of 5-FU and irinotecan have diarrhea, with about 30% grades 3 to 5, which is pretty severe diarrhea. We all know about irinotecan-induced diarrhea, right? Because this is almost always a question on the BCOP exam also. So early onset, which is a cholinergic type diarrhea, use atropine, and late onset, use loperamide. So these are some medications that you can use for diarrhea and when to use them. And they're also grouped into different classifications just for your own general perusal. So this is a picture, I know, of mucositis, just to remind ourselves of what mucositis looks like. And you know how it feels when you have just a cold sore in your mouth, a small one. Can you imagine the pain that these patients are in? When we go into a BMT patient's room on B66, I try not to look when they look in their mouth because it hurts to look at it. So mucositis ranges from inflammation to frank bleeding ulcers. 40 to 75% of chemo patients will experience some degree of this. It usually parallels with the nadir of chemotherapy. So usually you begin to see it 5 to 7 days. After chemo, you see it improving when their counts improve. Continuous radiation-induced mucositis depends upon the dose of radiation and the volume of tissue. So kind of like where the field is, how big the field is, what the dose is. And radiation and chemo is worse than either alone, which makes some sense. So to prevent mucositis, good oral hygiene, improved dentition. We often will send patients to the dentist before they start treatment if their teeth are really bad because we know that that's going to make things worse. No specific oral care regimen has been shown to be superior to another. The evidence just isn't there. Saline rinses is about as good as anything. Soft toothbrush, keeping their mouth clean. Interventions that have been shown to have effect are listed there. Kind of interesting. Palifermin times 3 days prior to conditioning regimens and 3 days post-transplant has been shown to be effective. We do not use this here, so I think it's an important thing for you to remember when studying for the BCOP exam. It's not on formulary here, but I saw bunches of questions during the question writing workshop on this very expensive drug.
Isn't there specific regimens it's shown benefit with too?
Yeah, there are. Yeah, you're right. So other than BMT, there are some specific, like head and neck, I think.
Yeah, they're in the packet.
Yeah, you can. I would look this up in the supportive care section. But there are specific regimens that it has been shown to have benefit with. I think most of them are head and neck, which makes some sense where the cancer is. So really only low-level laser treatment showed a reduction in the severity of mucositis. Do not use chlorhexidine, important to remember. Ranitidine or omeprazole for prevention of epigastric pain. So sometimes they get severe epigastric pain. So you kind of keep the acid down, helps keeping the mouth moist. And pain management is important. So PCA is often used when mucositis gets bad. So which of the following would you not recommend to treat moderate to severe oral mucositis? Which one has no evidence? D. Yeah. So allopurinol mouthwash there's no evidence for it. It's kind of left over from, you might see some older doctors still prescribing it. Have you guys ever seen it? No. Good. No evidence for it. So anorexia, cachexia, and nutrition. Multiple studies have shown a correlation between weight loss and decreased survival, and that's why we have nutritionists on our team of people caring for patients. Studies have also shown that loss of appetite correlates with poorer prognosis. Part of this too is just in general the body's dying process, and I think we need to remember that families trying to force feed, and really kind of focusing on that when it's really a natural process is something I think as pharmacists also we should remember. So cachexia is the main cause of death in up to 20% of cancer patients, which I thought was an interesting statistic. So basically remember that anorexia is the loss of appetite and decreased food intake. It's a consequence of cachexia, not the cause of cachexia. And cachexia in cancer is characterized by the following list of things. You see a lot of loss of protein stores. You'll see really unusually low albumins in cancer patients if you would look kind of at the end of life. So what can we do to help treat some of this? Most commonly used, of course, is megestrol acetate. 800 milligrams PO daily is one of the usual doses. Adverse effects aren't really common with this, but it can cause edema and DVTs. Progesterone acetate was used a lot in the past. Do you guys see that used anymore? I don't think it's used much. It's possible. Sometimes they use corticosteroids to kind of stimulate appetite because corticosteroids are kind of used for everything. Nutritional support. I think it's important to remember that TPN may be effective for short periods in patients with reversible GI obstruction, short-term GI toxicity from treatments, and in patients undergoing allogeneic BMT. And that's really about the only place it should be used in cancer patients. It's not effective in advanced cachexia or in palliative or end-stage care setting. And it can actually be harmful as well as not being effective. So we're winding up here, but just to talk a little bit about chemotherapy extravasation. Were any questions on this on the test, Jason? Do you remember?
Yes.
We're using Jason because he just took the exam a few months ago. They almost always have questions on what to do with extravasation. These guidelines are pretty clear, so I think it should be pretty easy for you. So just remembering what chemotherapy extravasation is, the inadvertent infiltration of chemo into the sub-Q or subdermal tissues surrounding an IV or intra-arterial administration site. There's different agents, so we divide them kind of into three groups. So non-vesicants, really, but they may still induce inflammatory reactions. Irritants can cause pain in the vein or in the surrounding tissue during administration. And vesicants are the ones we really worry about, as they're capable of causing tissue damage after leakage and may cause progressive tissue damage if it's not treated over time. So these are the big ones in vesicants. I think knowing that these are vesicants would be all you would need to know for the BCOP. Severity of extravasation is generally proportional to the amount of drug extravasated, so keeping an eye on it during administration by nurses is important. Some other considerations are pH, the chemical profile of the drug, osmolarity, molecular weight of the drug, and the amount and type of diluent that the drug was in. So if it's more dilute, it's a little bit better than doing like an IV push with doxorubicin. So here's some pictures of some not horrible extravasations. I actually used this in a PEDS presentation. This is a doxorubicin extravasation into the hand. And this is a vincristine extravasation in an arm. So I want you to understand that this is not, yeah, and I obviously should have looked at my spelling a little bit better, but it's not a complete review of supportive care in the management of cancer, but just kind of trying to help you start to study in this. I think supportive care is one of the easier things to study, which is why I put this one first. I think we're all more familiar with it. We use it more on a day-to-day basis, everybody. There's always a lot of questions on supportive care because pharmacists are certainly involved on a day-to-day basis with it. And I missed some of you before you came in. So on July 1st, we will have access to the 2015 BCOP review course and the lectures. So on July 1st, I'll be begging Mike Kaiser to help me post them correctly so that everyone can have access to them. Carrie, are you still on?
Yes, sorry, I was muted.
No, I know. I'll make sure that you guys have access to them over there too.
Perfect.
The PEDS one is really good this year, FYI.
Yeah, no, this is great.
Yeah.
I'm really glad to be included.
Yeah.
Thank you.
I'll make sure that you guys have access to this BCOP review material. We haven't bought the whole schmear for a couple years now because it costs like $500.
No,
But
it's wonderful.
okay,
Thank you.
all right. So just we'll make sure and send out. Our next one actually is on July 1st, so I should have access to it that morning. Any
Great.
Any questions or comments from the group? I appreciate the people that called in.
Thank you, Mary.
You're welcome. Thank you.
Yes, thank you.
Thank you, Mary.
See ya.